No, we're very enthusiastic, very optimistic. It's an exciting time. It's going to get more exciting over the next few years, but we're sort of crossing some thresholds now that will change the face of food allergy. Not just as these first treatments are developed and approved, but there will be, again, many new therapies that emerge. I told the young people this morning when I met with the medical students and the residents and then the fellows in training that in their career they may be using the word cure around the world of food allergy. There's a huge overlap between the different allergic diseases, overlap between treatments, and one of the really interesting things is that I don't say care for any patient of my 2,000 or so patients that only has food allergy. So food allergy tends to travel with asthma, eczema, allergic rhinitis. And one of the neat things about thinking of treatments would be whether there could be approaches that might do something above and beyond their food allergy. And if we did have a drug that managed the food allergy and also relieve them of their asthma, allergic rhinitis, and or eczema, that would be a really exciting breakthrough, and that's where some of the biologics may sort of fulfill some of that. And the other thing that I don't see ever is a patient who only has peanut allergy. So most of our patients have multiple food allergies. And one of the decisions that families will make of whether they decide to be treated for their peanut allergy is whether it really is going to make a very big difference if you still have milk and egg and wheat allergy. Because the milk and egg and wheat allergy are actually what limit their life. The peanut allergy does not. So we're also looking at approaches to treat multiple food allergies, either with the similar immunotherapy approaches using multiple foods, but potentially using some of the biologics that are not specific to a food, not just designed to treat peanut allergy, but may block a pathway that is common not just to your milk, egg, peanut, and wheat allergy, but to your asthma and allergic rhinitis. And that's where things start to get really exciting. That would be a tough call. If you asked 100 people here, you'd get 100 different answers. There are things that are available to do today, like give our patients better treatment approaches when they have an allergic reaction. That's something I can take back to the clinic this afternoon and make that person's life safer. My topic this afternoon in the plenary is about diagnostics. We have a huge barrier to making accurate diagnosis of food allergy, and the tests that we use are really dramatically flawed. There's a lot of bad information you get from doing food allergy testing, and we need to overcome that. And that is a big initiative as well. And part of that diagnosis piece will actually be very helpful in guiding patients as to who might be best candidates for treatment. Because there may be some who have a less risky form of the disease. There may be some who have a better prognosis to outgrow their allergy. And if we could do a better job of what we say phenotyping patients to really identify those that would be at highest risk of reactions from the small exposures. So if the treatments that are coming forward are really designed to prevent reactions from small accidental exposures, we would like the treatment to focus on those patients. There are lots of patients out there who don't have that risk. They're not that allergic, even to peanut. So a part of the development of diagnostic testing would ideally be able to identify that group of patients that would benefit most from being treated.